Good afternoon, ladies and gentlemen. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Jennifer Zelmer, President at the Canadian Foundation for Healthcare Improvement. Please go ahead.
Thanks so much, Val, and hello and welcome to everyone on today's webinar about value-based healthcare by design, identifying promising innovations in a Canadian context. We'll begin the webinar today by acknowledging that we're meeting on land that has been inhabited by Indigenous peoples from the beginning. In particular, we acknowledge that we're broadcasting this webinar from the traditional unceded territory of the Algonquin and Anishinaabe people. We recognize and deeply appreciate their historic connection to this place, as well as the opportunity to gather here today. We also recognize the contributions that First Nations, Métis, Inuit, and other Indigenous peoples have made in this community, and all those from which people are participating in today's webinar. We invite you to participate in this webinar either in English or in French, and we're providing simultaneous interpretation to make this possible. Bienvenue au webinaire. Si vous participez maintenant en anglais et vous préférez le français, n'hésitez pas de nous en informer à l'aide de la boîte de dialogue. It's great to see everybody introducing themselves, to see some people I know and some new friends introducing themselves in the chat box, and I encourage you to do the same so that everyone gets a sense of who's on the webinar today. We have more than 300 people registered, so we're delighted to have participants from coast to coast to coast in Canada and beyond. My name again is Jennifer Zelmer. I'm today's host for the webinar here at CFHI. And it's part one in a series of webinars we've planned to focus on value-based healthcare. Before we get started, there's a few very exciting housekeeping items that I'd like to mention. I'll be introducing our speakers shortly, but as I said, feel free to introduce yourself in the chat box. Throughout the webinar, you can also use the chat box to send in your questions in English ou en français. We'll stop between presentations to respond, and I've also reserved some time at the end of the webinar for Q&A. Please also, this is an all-teach, all-learn process, one of our true beliefs here at CFHI, so please feel free to share links and resources you think might be of interest to others in the chat box as well. And finally, for those who are on Twitter, we have a hashtag for you. You can join the conversation with us by using hashtag VBHC, so for Value-Based Healthcare Webinars. So for those who've just joined us today, welcome to this webinar on value-based healthcare by design. And I'm going to provide an introduction to value-based healthcare just to get us started, have a common understanding what it is, what it isn't, some key enablers, some examples from Canada. And then afterwards, I'll focus on a set of assessment criteria that can be used for selecting or developing a value-based healthcare initiative. But I'm super excited to be joined by co-presenters Neil Fraser and Deb Klein, who I have the pleasure of introducing. Neil is the President of Medtronic Canada and Regional Vice President for Canada for Medtronic. He's also the Chair of MEDIC, a board member of Baycrest Health Sciences, and a member of the federal government's Health and Biosciences Economic Strategy Table, which is the primary hat that he'll be wearing on the webinar today, because in his presentation, he'll be sharing some highlights from his role on the government's Health and Biosciences Economic Strategy Table, including their fall 2018 report recommendations around value-based procurement. Neil's a frequent speaker on the topics of value-based procurement and outcomes-based healthcare, and in 2014 he was a member of the Federal Advisory Panel on Healthcare Innovation and the Ontario Health Innovation Council. He'll be followed by Deb Klein, who's the VP of Innovation and Strategic Partnerships at Plexus, a not-for-profit shared healthcare services organization. In this role, Deb works with a wide array of stakeholders to enable Plexus hospitals to acquire products and solutions to support patients through value-based healthcare, innovation procurement, and the development of new business models and partnerships. Previously, Deb was a director in PwC's healthcare practice and was the Ontario Hospital Association's program leader for financial management. Dov received his MBA from Rotman, his MEd from OISE, with a focus on policy, leadership, diversity, and change. And his presentation today will cover Ontario's recent procurement initiative for cardiac devices and how it was shaped through a patient engagement strategy. Welcome to Neil, to Dov, and to everyone who's on the line with us today. So, getting started, just a couple of seconds on who CFHI is. So we're a national not-for-profit organization funded by the federal government with a focus really on how do we provide and how do we help our partners to provide more improvement for more people right across the country, and improvement that lasts. We do that in four main ways. The first is for areas where there are known problems but not known solutions, to identify innovators, connect them with each other, and help to raise the profile of their work. The second area, which is where a lot of our activity happens, is focused on where there are proven innovations, helping to spread and scale them so that more people can benefit. The third area where we work is supporting improvement-capable health systems. So we support extra fellowships for health leaders and teams. We work with Patient and Family Advisor Network across the country, and many other activities that hopefully help to be the tide that lifts all boats in improvement. And last but not least, our fourth area focuses on the policy and system enablers and barriers to healthcare transformation. How can we make the right thing to do the easier thing to do, and work with our many partners across the country in so doing? And that's where much of our work on value-based healthcare comes in. So what is value-based healthcare anyway? There are whole PhD theses that have been written on the definition of what is value. So there's a number of ways that it can be defined. For the purposes of today's conversation, we're borrowing some work by Porter from Harvard, really focusing on that relationship between outcomes that matter to patients and the resources that are used over the patient's journey. So it's not about the numbers of services provided or specific products or processes that may or may not achieve those outcomes. It really is that focus on outcomes that matter. And so it's one way of instantiating patient preferences, expectations into a broader health policy approach and to funding and procurement. I think it's important to sort of hold in our minds that this is about how can we use our resources, both money and other resources, the most effectively. It's not about the specific dollar amounts that are spent on a particular product or service. It's about that relationship between overall outcomes and resources used. Just as important as what value-based healthcare is what it isn't. So it is not about driving down the lowest cost if that doesn't improve outcomes. It's not about taking a narrow slice of an individual component of an episode of care in isolation. Rather, it's usually about looking across an entire episode of care or population group, a more holistic view, if you like. It's not the same as a straight pay-for-performance model that reward the delivery of specific care processes. So did you do X type of screening, for example? And it may actually go broader than only the health sector. So it may include interventions, for instance, from the social sector or from other areas in broader types of interventions that improve outcomes that matter to patients. Bottom line, value increases when the total cost of achieving the same or better outcomes fall. This is a summary that the World Economic Forum put together a couple of years ago now, and their sort of conception of a focus on a patient-centric way to design and manage health systems that really focuses us on the full outcomes, the trajectory of care. There have been a number of studies over the past couple of years around value-based healthcare and what it really takes to make this work. And we did some analysis last year to basically line these various reports up against each other, and this is a summary across them of the common characteristics that were identified. So key enabler in terms of the context, the policy, and the institutions. So we need to have the mechanisms in place to make it easier to implement value-based healthcare. So for instance, to be looking and understanding what matters to patients. What are the outcomes that matter? How do we look at those? How do we embed some of these actions in a policy environment? How do we ensure that our procurement capacities or our funding mechanisms are well aligned? The second, measurement of costs and outcomes. And obviously these are measurement of costs and outcomes that match with the perspective of value-based healthcare, so that match, for instance, with the full episode of care, not just a piece of it. Another key enabler of value-based healthcare is looking at care pathways and integration. So it's much easier to be able to achieve value across an episode of care if there are mechanisms to support individuals through that journey. And last but not least, the reports also identified outcome-based payment approaches as a key enabler of value-based healthcare, a mechanism, not the only one, but an important mechanism that can help us to drive forward. With that last as a caveat, though, an important caveat from Steve Morgan and his colleagues, that of course no financial mechanism, no payment model is a silver bullet. This obviously has to take into account the broader organizational arrangements, clinical arrangements, engagement with patients and families and other processes, as well as the legislative and regulatory environment in which we're working. One of the things that we did last year is we had a summit around value-based healthcare, and then a follow-up with a smaller group to help us really navigate what do we know from a Canadian context in terms of what helps. And this series of sort of advice, we challenged participants to say, what could we start doing, what could we stop doing, and we gave them extra bonus points for stop doings that would help to accelerate value-based healthcare and their impact. And I won't go through and read them all for you here. You'll see the broad perspective. But you can also see that this brings together a number of different aspects of success. So that there's a proactivity, a leadership, but also some technical questions around, for instance, value-based procurement capacity that we need to accelerate progress as well. As we were starting down this journey, there's some well-publicized examples of value-based healthcare internationally. There aren't as many that have been shared in a Canadian context. So we wanted to draw together what do we know about Canadian experiences in value-based healthcare to date, what are some of the lessons learned, so that hopefully we can build on those experiences as we go forward. And I'll share a link for you in a minute. We have done a series of profiles of different kinds of value-based healthcare initiatives in the country, and there are links there as well if you want more information. Just before I dive in, I've been asked to remind everyone that if you've just joined the webinar, please introduce yourself in the chat box so that everyone knows who's on the line and who's joining us today. And feel free at any point during the webinar to add questions into the chat box, or if you've got suggestions for resources or tools that may be useful to others on the webinar, please feel free to add them there as well. Bill's just added a link to CFHI's work on value-based healthcare, including the case profiles that we've done, and we've got actually more under development as well, so you can keep coming back to that space for more information. So the first set of profiles we did looked at outcome-linked funding, where the amount of resources that a healthcare provider, could be an individual provider, could be an organization, receives depends on the extent to which predefined health outcomes are achieved. And there have been a number of examples of this in Canada. One of the ones that we profiled was some work that had been done around telehome care for individuals with serious chronic conditions, such as CHF or chronic obstructive pulmonary disease, where resources were dependent on progress in terms of health outcomes, as well as in terms of things like avoiding potentially avoidable visits to emergency departments and hospitalizations. There's also been a series of work that's been done more on the public health and population health side that's been exploring social impact bonds, although there's some additional development on the healthcare side now underway in this area as well. Social impact bonds are a relatively new tool globally, and they reflect a pay-for-success model. One of the largest ones in Canada in the health sector is the Community Hypertension Prevention Initiative, involving a whole range of partners that is intended to really focus on individuals who are at cardiac risk and the ability to reduce their risk over time, focusing on the management of risk factors and self-management. And then a number of initiatives as well that we identified and profiled that include risk or gain sharing contracts, organized in a variety of different ways. And you'll hear a little bit about some of that work on the webinar today and more at an upcoming webinar that we're planning as well. So if you're interested in these kind of areas, there's also more to come in the webinar series. So with that whistle-stop tour through value-based healthcare and some of the resources and work that's been done in Canada, if you're interested in more information, you can follow up at the link on your screen or the one that Bill typed into the chat box. I wanted to make sure that we had good time on this webinar as well to talk about the broader context, both the broader policy context and then a specific example of the use of value-based healthcare in Canada. So to start us off, I'll just pause here and see if there are specific questions that have come up already. I'm not seeing any at this point, so we'll just dive right in. And I'll turn things over to Neil Fraser, President of Medtronic Canada. He's going to talk a bit about some of the federal policy environment and the work that he and colleagues have been doing as part of the Health and Biosciences Economic Strategy Table. So Neil, I'll be turning it over to you.
Yes, good afternoon everybody. I'm here at Mars actually in Toronto, and I'm just going to be highlighting some of the key recommendations coming out of the Health and Biosciences Economic Strategy Table that relate to this specific area of value-based healthcare. We can probably go to the next slide. Sorry, is someone changing the slides?
Yep, should be up in just a sec. There you go.
Okay, good. So basically, the economic strategy tables were created and largely identified by the consulting firm McKinsey, who basically identified that in Canada, although we're enjoying some good economic growth at the moment, it's anticipated that the GDP will actually start to decline in the next 5 years. And so the focus is really to identify sectors that we see tremendous growth potential in. And you see the 6 that they focused on there, but I'm only going to focus on health and biosciences, so we can maybe flip to the next page. We were a group of about 15 people, chaired by Karima Escobar of Quark Ventures from Vancouver. The specific focus that we had was to look at how could we double the exports and double the number of companies, of innovative companies in the healthcare sector in Canada. And then within that, we identified specific objectives. And I was charged actually with the first 2 of these, but I'm only going to focus on the first one, which was specifically, we called ourselves IPAC, and we focused on innovative procurement, adoption, and commercialization. And just to bring this into focus a little bit, one of our colleagues on the table is a fellow named Armin Bakurtsian of IntelliJoint in Waterloo. He's an entrepreneur, an inventor. He invented a very interesting tool for use in knee surgery and hip surgery that allows you to orient the device very accurately to reduce the number of revision surgeries. Unfortunately, though, he's been a great success everywhere else but Canada. And so, he really brought home the issue that he cannot have his product procured in Canada for a variety of sort of structural and procurement reasons. So he was a constant reminder to us of some of the shortcomings of our processes in Canada. Also, I would just add that we did consultations with folks across Canada. Interestingly, the next speaker, Dov Klein, was part of one of our consultations because he's such an expert in this area. Just to focus then, to focus on accelerating innovation adoption, one of the key things that we identified was the need to use value-based procurement across the Canadian health systems, and really to establish expertise. And one thought was to create an agency that would fund sandboxes where all of the resources could be pooled to solve important problems in the healthcare system. We can go to the next slide. So why do we feel that procurement is a challenge? Is that procurement today in Canada, and I'm sure Dov will talk about this, largely focuses on procuring things that might perhaps come in a box, and yet the focus of health technology is really to improve the patient's journey and to focus on the quadruple aim, that was coined by Donald Berwick of the IHI, which is to focus on the patient's experience, the cost of delivering care, the health of the population, and also on the experience of the caregiver. Basically what we are recommending is that value-based procurement needs to be spread and scaled, much like the model of CFHI that we've just heard from Jennifer Zelmer. And we are going to be focusing in our implementation phase on identifying, we'll call them sandboxes, but areas that address the most important problems in healthcare across the country, and finding willing partners at the provincial level to participate in this initiative. So with that, I'll turn it over. Actually, I'll open it up for questions.
Thanks, Neil. We've got the first question that's come in. Could you just give people a little background on who the Health and Biosciences Economic Strategy Table reported to? A little more context.
Yes, this was part of the ISED ministry, the Innovation, Science and Economic Development Ministry, which is led by Navdeep Bains, Minister, as well as John Nubley, who's the Deputy Minister. And we actually had David McGovern, the ADM, directly involved. We also pulled in Simon Kennedy, who's the Deputy Minister of Health, for this specific table.
Great. Thank you very much. And just a reminder to everyone that at any point during the webinar, you can include questions either in English or in French in the chat box, and we will direct them appropriately. And Neil will have a chance to come back to you if there are additional questions when we do the Q&A at the end. Thank you so much.
Excellent.
So moving from the broad federal policy landscape to a specific example from Ontario, it's my pleasure to turn the webinar over to Dov Klein, VP of Innovation and Strategic Partnerships at Plexus. Dov, over to you.
Thanks so much, Jennifer, and Neil, thank you for the introduction. So just in terms of what I thought would be helpful to cover today is a bit of a background to the provincial initiative that we undertook with the support of the Ministry of Health in Ontario and Core Health Ontario. We want to talk a little bit about how we define value, how we brought the patient perspective into it, the goals of patient engagement, and how those linked into the ultimate procurement goals for this category. And while this is still a project in motion, we do have some value that we think we've created to date that we'd like to share with you and obviously chat about and obviously take any questions that you might have. So just to provide you a little bit of background of kind of where we've been and how we got to today, Plexus has taken out the ICD and CRT category to market sort of several times over the last decade or so, in largely traditional ways, to be honest. And over that time, saw pricing come down quite significantly. But over that time, I think as an organization, we recognized that there was more to be done from our perspective in the value that we could create both for our hospitals and for patients. And we knew that beyond just simple price, there was a lot of gaps in the system that patients in particular were experiencing. Just from talking to our hospitals, we knew that how patients transverse the system, they may get an ICD implanted at a particular implanting center but seek care in other parts of the system, yet have to maybe sit in an ambulance or sit in a car for hours to then go back to their implanting center to receive care. And we knew that wasn't good for cost of the system nor for patient experience or outcomes. We knew that there are patients throughout the system still receiving shocks at end of life when they're palliative and at home. And we also knew from just a pure hospital perspective that the demand on volumes and growth and on funding was just continuing unabated. And so we recognized that there was something more that we could do in this sector. And so we approached the Ministry of Health and Core Health Ontario and said, listen, maybe there's an opportunity to do something here. There's only 12 hospitals in the province that implant ICDs, so it's not like it's 50 or 70 or 100. If we want to try something and see if it works, this is probably the right amount of hospitals to do it with. There's great data. So we have an Ontario registry that tracks and follows every single patient who receives a device in the province. We know for many parts of the patient journey or episode of care what the costs are for those patients. And we also know that there's just been a general trend, particularly in Ontario and in Canada more at large, to really start looking at what Neil referred to as more solution-based approaches to some of these challenges that patients face. And we thought that if there was ever a time to do this, it was now. And it also didn't hurt that all 12 hospitals happened to be at the end of their contract at the exact same period of time. But beyond that, we just felt that this was an opportunity to do something different. And with the support of the Ministry of Health and with Core Health, we went about our work. And so very early on in the process, we really wanted to make sure that this was really rooted in the patient experience and how the patient experiences value, obviously taking into account also obviously the cost to achieve that value. And this is a slide taken straight out of Porter and Kaplan's Harvard Business School course on the topic. Jennifer referred to the equation earlier on. But one of just to be honest, one of the big challenges that we had with ICDs is that when you look at the equation in terms of looking at the outcomes for a patient over the full cycle of care, that works pretty well for kind of an acute episodic type of patient who the entry criteria are clear. We know when they become a patient. We know when they leave being a patient. For something like ICDs and for heart failure patients, this is something where they experience their disease over years or even decades. So one of the big challenges we had in this is really being able to look at the funding model that exists in the province, which really is just about the implantation of the device and some limited follow-up afterwards, versus a patient who needs to now experience and live with that device as they transverse this quite complicated healthcare system that we have. And quite frankly, the funding model also sort of set it up so that there was quite a high price for an ICD, but that money is used not just to implant ICDs, it's used to implant all sorts of other things and other cardiac surgeries and really subsidize, or not, I shouldn't say subsidize, but really support the entire cardiac portfolio across the hospital. And so that's just, again, a challenging place to start from. And we knew this wasn't going to be perfect, so we're not suggesting this was the perfect strategy. We call it more of a best fit approach, where we try to take all the different constraints that we had to come up with something that we thought could better meet patient needs and outcomes at the end of the day. And to the ministry's credit, they were a big partner in this and ensuring that hospitals would have the ability to take any savings or value that was created from this process and reinvest it back in the cardiac program. So it didn't go to orthopedics, it wouldn't go to DI or maybe other parts of the hospital, it had to stay within the cardiac program with the idea that would be reinvested in the episode of care. So that's how we sort of started the process, really focused on patients and focused on what we were paying for as part of the process. In terms of patient engagement, again, relatively early on, we worked with Karen Harkness from Core Health Ontario, who was a nurse who cared for these patients, who lived with them through their disease to really come up with a framework for how we were going to go about doing patient engagement. So we certainly weren't starting from scratch. And we really believe that if we could understand why or how patients experience their care and where the gaps are, we could actually reflect both patient needs within the procurement, but also weight their needs properly within the procurement. So every procurement has different weightings of points. We wanted to make sure that the things that matter to patients were weighted obviously the highest versus other things that might not be as important. So specifically, we wanted to understand what it was like to live with a device, the impact on families and the personal life of the family and the patient. We wanted to understand the gaps in supporting patients living with a device, the elements of care and support that patients value. We wanted to make sure that also we gave suppliers an opportunity to respond to those needs identified by patients. You know, Neil mentioned earlier about sort of the movement of the medtech industry towards solutions. We know that 7 of the 10 largest medical device companies by revenue don't call themselves device companies anymore. They call themselves solution companies. They want to go with the hospital or the care provider to actually achieve an outcome. And so by understanding what these challenges were, we could give suppliers those opportunities to do that. And so these were some of the overarching goals that we entered the process in. I won't go into the next slide in much detail, but you know, we also didn't want to just start from scratch. There's been a lot of research, qualitative research in particular, on patient experience living with devices, the challenges that they face, and so we also spent quite a bit of time grounding ourselves in some of the core literature in the area so that we made sure that we understood what we were going into, we could design relevant questions, and that we really were focusing on a local Ontario perspective in our patient engagement activities. So working with both CoreHealth and CanNet, we went out and tried to recruit patients for 1-hour interviews. And we had a very, very broad inclusion criteria. So, you know, if we did this again, we may have changed this a little bit, but we really went out in quite a broad way to make sure that we were getting patients from across the province, different parts of the province, and really trying to understand all the different types of patients that exist. So obviously, if you've recently had an ICD, if you've had a replacement procedure, you know, you've experienced remote monitoring, had shocks, travel long distances, and also have experienced both treatment in an academic center and or a community center. Those were all kind of things that we really, really wanted to understand from a patient perspective. And we didn't want to make it procurement focused, as procurement professionals kind of tend to do, but really focus on patient focused questions. And we really we try to help patients describe to us what are sort of the trade-offs in your own care that you could help us understand better. So for example, longer lasting devices versus devices with the latest technology, right? Would you be willing to have another procedure to get the device with that newest technology? Is that trade-off acceptable to you, all things being equal? So on and so forth. Really trying to just understand, again, from the patient's perspective, where we were going from and where we're trying to get to. Just to give you one example of kind of one of the patients that we spoke to and kind of the feedback that we got, this is Patricia. Obviously, her name has been changed, but this was a 39-year-old nurse who had a sudden cardiac arrest, had 3 children, and was living with a device for for a very, very, very long period of time, and is expected to live with this device for many decades. And really diving into her experience was really quite shocking and enlightening, just to understand kind of the impact of living with a device on her family, on herself, on her ability to work, on her ability to transverse the system, things like the impact of education, on really understanding, what was being implanted inside of her, the size and comfort of that device, and really being able to say, hey, listen, I would have maybe preferred a smaller device, all things being equal, if I had that choice. Really being disappointed that remote monitoring, although it was available, was not turned on in her case. And also just the general challenges moving through the system and experiencing care in different ways. I mean, I think it was just really, really grounded us in really lived experience of patients. In terms of how that all rolled up into our provincial strategy, basically there were 5 key elements that were really clear pretty much across every patient as we went through this. So some of them were things like consideration of device characteristics. So patients were invariably interested in longer lasting devices. They pretty much would do anything they could to not come back into hospital if they didn't have to. But impact of device size on physical experience, technological enhancements, remote monitoring, and the need for MRI compatibility. patients did not appreciate the fact that that in many cases they were receiving devices that would preclude them from having an MRI later in life, and that, particularly for younger patients, was a really, really big concern and something that really stuck in our mind as we went about our approach. Education and awareness, obviously a big, big issue in terms of the impact on their daily living, lives of their families, and also for many patients on what that meant for end of life, on whether they were getting the right education about device deactivation so that they wouldn't receive shocks at end of life. That was a big thing that we heard, and we know, at least in Ontario, Core Health has worked on a strategy around improving some of those outcomes in that area. Patient experience, again, was another big thing we focused on. So the pain of having a replacement procedure or having the initial procedure, the physical toll that it takes on them and their families. Clinician contact and support was a big area we heard about as well. So being able to talk to their care team afterwards, be in touch with their care team, and really being able to feel supported post-implementation. And then another big area which we really kept top of mind was device assurance. So patients are really anxious and have a lot of anxiety when they receive these devices, particularly around getting shocks, inappropriate shocks, device failures or potential for lead failures. These were things that really, really worried them. And when remote monitoring was not turned on and they couldn't sort of have that assurance when they went to sleep that someone somewhere was watching over them, that was a big disappointment to them and something that they really thought was important, as long as the security of their personal information could be guaranteed. And so, again, these were just some of the big things that came up as part of our conversations. And while we weren't trying to be statistically significant, we were trying to be directionally correct and really trying to create a framework of how to create value for patients as part of this process. So in terms of how we then work that into a provincial procurement, we really tried to look at it from 4 distinct areas: the patient, the providers, so the hospitals and physicians, the broader health system, and also the vendors or suppliers, or in this case, medical device companies. We wanted to make sure that we could find elements of value that touched on all of them, but again, all rooted in the patient experience. So for patients, some of the obvious ones we've already talked about, things like minimizing lifetime device replacements. A traditional procurement would take a $4,000 device that lasts 4 years and weight it much higher financially than a $8,000 device that lasts 8 years. And that's really a silly way to look at pricing if there's such a big difference in how long a device actually lasts and all of the significant costs that would come if a patient would come in earlier for a device replacement. Looking to improve outcomes for heart failure patients, ensuring the latest technologies, ensuring that there was ease of follow-up and improvement in quality of life, and making sure that patients could get access to care closer to home. Those were some of the big things that we focused on. From a provider perspective, ensuring that they can manage their financial pressures is top of mind in Ontario, a big, big issue, as you all know. They wanted to be able to reinvest in the newest technologies. As we know from patients, having access to those technologies is important. They also wanted to make sure that there was equity in service delivery. We have quite a large province, as you know, with many different distinct areas, and I think there was a feeling that service will depend a lot on where you are. And so what we wanted to do is basically create a standard level of service that wouldn't matter whether you were in downtown Toronto or Ottawa or London, but it would also be if you were in Sudbury or the patient showed up in Thunder Bay, that there was a certain standard level of service and support or warranty that could be expected as part of that patient's experience. Also explore mechanisms for partnership with vendors was really important, and from a physician perspective, really being able to maximize clinical flexibility and choice so that they could give the right patient the right device at the right time. From the health system, I think it was pretty self-explanatory. Things like transparency of inputs, ensuring value for money, increasing capacity were all of interest to our health system. And then from the vendor's perspective, we really wanted to focus on making sure that they also would be able to get value out of this. And on the most basic level, we stopped putting 5,000 requirements into an RFP. We really tried to focus on what are the real things that matter in the device from the physician and from the patient perspective, and give the medical device companies real opportunity to highlight their innovation in that particular area. So we weren't just looking at things that we know everyone's the same at. Where can you really be distinguished as a company? The other thing that we looked at was, and that goes goes back to my comment earlier about solutions, we wanted to give the opportunity for vendors to become more deeply ingrained in the episode of care. So if we could actually provide the vendors with challenge statements and things that were problems within the system, if they could help us solve them, that could be the basis of some of the elements of the procurement. And then finally, a sustained opportunity for open access to the market. We weren't interested in a 95% commitment to one vendor. We wanted to make sure that every single vendor had a sustainable business in the province. Increasingly, particularly for Plexus, as we look at more provincial opportunities, we are very concerned about creating unintended consequences both for vendors or for supply chain risk. And we wanted to make sure that the outcome allowed all vendors to have meaningful business moving forward. In terms of the project scope, you'll get these slides after the presentation, so I won't go through this in detail, but we looked at sort of 4 categories. The first was devices and leads, and this was, I think, one of the biggest deals of the whole process. We're the first jurisdiction that I'm aware of that's made a commitment for both devices and leads to the same vendor. So there was a primary commitment at a minimum of 50% for one vendor, and the reason why we made that joint commitment to the same vendor is that it would ensure MRI compatibility for that patient. Many jurisdictions sort of do a 100% open share for leads, but we wanted to make sure, and we got all the physicians at the provincial working group table to agree that moving forward, we would only be implanting MRI-compatible devices. So really, that's what we heard from patients, that's what we knew were important, and that's what, at a provincial level, we were able to move forward on MRI compatibility. So that was a really big deal. Service, as I mentioned, making sure that there was equity in service in terms of how that worked across the province, and ensuring that a patient who does have a device problem or issue outside of their implanting center could experience a standard level of meaningful support from a vendor or from the hospital. And finally, remote device monitoring was another big area. There's CADIF and OTAC recommendations around funding remote device monitoring. It is not funded in Ontario right now. The expectation is that hopefully over time that will be the case. But even without funding, many, or I would say most, Ontario hospitals are starting to ramp up their remote device monitoring programs. And so we wanted to make sure that not only were we supporting that the procurement could support hospitals who are trying to move to scale on remote device monitoring, but also allow the vendors to help scale up a brand new program, or some of our hospitals who hadn't actually set up any type of remote device monitoring program to date. And then the last area was around the value-add solutions, which we've talked about, which was really to provide the challenge statements for all the vendors to see of what are the biggest problems in Ontario, and are there additional warranties, risk-share structures, programs or services, or other ways for us to go into partnership with the vendor community in achieving some of these outcomes. And so there were 10 challenge statements that were in the RFP. I know I'm running short on time, so I'll just start to wrap up. But these were the kind of the big 10 areas that there were massive issues across the sector. And in great detail in the RFP, we detailed all of these different challenges that the system was facing, and asked vendors to propose how they would work closely with hospitals and with the province to address these areas. So to wrap up, while the RFP is still in process, many of the hospitals are still going through their evaluation approaches, or their evaluation processes, I should say. There are some tangible takeaways of things that we've been able to create through this process, which we're proud of, and we're hoping will be a start to other things like this in the future. So the first one, from a patient's perspective, is we've heard them, and we're enabling the consistent use of MRI-compatible devices across the province. As long as the patient's appropriate for it, the expectation is that they'll get an MRI-compatible device. From a device warranty and service perspective, we've now really removed that contract from being a vendor or device company to hospital relationship to really a patient perspective or patient relationship. So if that patient shows up with a lead fracture or device failure in other parts of the province, not their implanting center, we've basically standardized what that looks like from a care perspective from a patient. From a hospital's perspective, we've been able to really support and create some transparency around remote device monitoring for all 12 centers. They now know what the cost is, how to scale up, and what it looks like for that cost over a patient's entire lifespan, not just the budget cycle. So that's a big area, and we've been able to give them a sense of what's the total cost of care using the Core Health Registry, using other registries. They know what the care for that patient costs across that lifespan for that patient. Some of these other ones I've spoken about. From the system perspective, we've also been able to ensure vendor-specific physical interrogation technology exists at all implanting sites. So there's been For example, some challenges where patients would show up, let's say for cancer treatment at a hospital that wasn't their implanting center, and that vendor's physical technology didn't exist. So that patient then had to sit and then go back, and they didn't have remote device monitoring turned on, so that patient would then have to go back, maybe travel for hours or sit potentially in an ambulance to get their device interrogated at their implanting center. And what we basically made as a mandatory requirement is that the physical technology for all 5 vendors has to be at all 12 sites at a minimum, so patients won't have to transfer between sites. We've also, as I mentioned, developed the 10 system-level problems that the vendors have all responded to, and we're hoping to see how those work out. And then from the vendor perspective, at this point, all 5 vendors have qualified. They're all are likely to retain a significant market share in the province moving forward. And we've also given them that opportunity to be more ingrained in the episodes of care. So with that, open to questions. Again, we're not suggesting that this was the perfect approach, but it was, I think, a thoughtful approach with a lot of partnership and really trying to move the needle on some of the stuff in Ontario, and I hope we've achieved that.
Thanks so much, Dov. Really appreciate that overview and understanding of something that is still a very alive initiative as you go. We do have a couple questions that have come in for you, and as a reminder, if others have got questions, please feel free to type them into the chat box. The first question is maybe just can you talk a little bit about how you made the transition from the work that you did in focus groups and in interviews with individual patients into the requirements that you then put out through either the challenge statements or the other requirements in the procurement?
Yeah, sure. It's a great question. So we had a provincial working group where all 12 centers, physicians, administrators all sat on the table. And essentially we facilitated the process. We brought the information to the table. We brought all the different sort of requirements from the various hospitals also to the table and basically matched them up to say, guys, like, this is what you're asking for. These are what patients are saying. These are the clinical needs from the physician community. How do we match these up, and how do we balance these off in a meaningful way? And there are trade-offs, certainly in all of that. But at the end of the day, it was the 12 centers ultimately making that decision. And again, we tried to link up every single question we asked back to a core patient need as part of the process. And it took months and months, just to be honest.
Yeah, well, and I mean, that's actually not a bad segue into our next comment, actually, because this is still a relatively new process. And so there are other areas, like critical care or other end-of-life situations that may also be candidates for outcome-based access to appropriate devices. Maybe based on some of your lessons learned, are there things that you see as future opportunities? What would you see as the ways that you might be able to look ahead, whether it's within the province or even maybe nationally, and looking at really that participation of patient partners more actively?
So I think there are tons and tons of opportunities. I think there are also just some fundamental challenges. And so ultimately, when you're looking at caring for patients outside the 4 walls of the hospital, and to be clear, in Ontario, that's how hospitals are funded. They're essentially funded for a patient who enters their 4 walls and until they leave their 4 walls, and there's very little ability for a hospital to invest and then realize the benefits of those investments in either the primary care sector or post-acute sector or in other sectors, and that makes a really, really, really challenging to have hospitals make the investment yet and sometimes quite significant investments, yet not see some of the benefits. So, I mean, there are so many, whether it's in cardiac or renal, I could go on, where if we were able to match up the funding model to the actual patient journey through the healthcare system, seeing the hospital as an important but not necessarily central to that patient care journey, we could take many, many things out to market in very, very outcomes-based ways. I mean, even, you look at heart failure or COPD, I mean, the fact that the patient's showing up in the hospital is essentially a failure of the system, yet that's where the funding model starts in many cases, when that patient is in an acute setting and now needs to transverse get an ICD maybe, and then go back into the regular population without remote monitoring, without other technologies to support them. So really anything that moves across sectors and that is supporting particularly chronic patients would have a massive payback by doing it in this way.
Great, thanks so much, Dov, and great to see all the questions coming in. I'm doing my best to take them in the order in which they came in, and where there is sort of related questions to combine them so that we get as many questions as possible in. There's one more specific one for you, Dov, and then there's a few general questions that we may save for the Q&A at the end. So the specific one, can you just remind us how many patients you included in the qualitative interviews and the other processes to garner perspectives and requirements?
Yeah, so in terms of just the pure requirements, that came from the 12 hospitals and the physicians represented at those 12 hospitals. So they were the ones who were making the case at the end of the day. In terms of the patient population, it was smaller than we hoped. One of the challenges that we had in terms of recruiting patients is that a lot of the patient registries of patients who would be happy to participate, we can't actually, we might know that they have COPD/CHF, but we might not know that they actually have an ICD. And so we weren't able to use sort of the leverage some of the big registries or other support systems. And so we brought 10 patients to the table for these 1-hour interviews. Not what we had hoped for in terms of a sample size, but we did, we had our qualitative researchers from Core Health and from CanNet who reassured us that the information we were getting was meaningful and relevant to helping us ground the procurement in a patient-centric focus. We also had obviously all the hospitals and doctors and nurses around the table who could also validate the concerns of the patients and also bring their own experiences from dealing with patients to the table. But certainly if we did this again, we would expand the sample size.
Great. Thanks so much, Dov. So we're going to keep a couple of the general questions for the general Q&A that will be coming up. Just before we do that, I wanted to introduce you to one other resource and set of work that's gone on and get some of your feedback on it as well. So one of the questions that came up as we have been going down this path from partners we've been working with across the country was, okay, so I'm interested in value-based healthcare. I see the potential on a variety of fronts, but where can I start? And how do I, if I'm considering a couple of options, how do I assess the readiness to go ahead and the risks? So we actually brought together a group for people from across the country, including both Neil and Dov and a whole range of others over the summer, and asked them, based on their experience, what are the key characteristics that need to be taken into account in assessing the opportunities for moving forward. And the top 4 that were identified were having meaningful metrics, things that you could leverage, preferably that were already developed and tested and harmonized, not necessarily that they had to be absolutely perfect, but that they needed to be fit for purpose for the initiative that they were moving forward with. The second was for those metrics to have both outcome and cost data available. So much easier where those data already exist, where there's an existing mechanism to collect and standardize those data, but to be able to understand more broadly what would, if those data don't exist, what would be required to achieve that patient-based data collected at a level and in a way that aligns with the scope of the initiative that's going forward. Number 3 on our top 4 list was having a clear scope, so clearly defined target for the work, so which patients, which outcomes matter, who would you reach out to for things like the work that Dov described in terms of interviews with individuals, and recognizing also that we may need to consider timing in that context. So in some cases, particularly with chronic conditions, you may have individuals who are part of a group for a long period of time. In other cases, you may have people who move into or out of a population group. So for example, if you were focused on a group of individuals who might live in a particular geographic area. And last but not least of the top 4, material impact. This was sort of lessons hard learned by some folks who've been going down this path in terms of understanding upfront the probability that you can actually move that mountain and of influencing value for individuals, so the scope that you're able to focus on and then the impact that that would have. And in addition to those top 4, there was a series of other issues identified, so to be able to understand the potential and existence of clinical leadership in an area, the ability to focus resources on a particular challenge, permeability between silos, a fancy way of saying if individuals are receiving care, for instance, across geographies or across silos in the health system, can we actually join those up, move resources as necessary? Supportive policies and structures, not just on the funding front, but also, examples came up of areas where there were existing really well-established patient communities that might be easier to tap into to understand what mattered and what outcomes would matter than there might be in some other areas. Well-aligned payment models, also recognizing that this is a relatively new area, and so understanding the capacity and skill for value-based healthcare, where that was possible to leverage it. Situations where there were proven solutions in place. So are you going out hoping that somebody can solve a problem that you're trying to address, or do you know that there's proven solutions out there? And last but not least, how long would it take you to achieve that value? So different approaches that might be relevant in contexts where you might be intervening on a preventative basis and expecting to see things change maybe 20, 25 years down the track versus something that might have a much more immediate reflection in terms of outcomes. Just to give you a sense of some of the things that came up when we had our design day in the summer, and we would love to have your view on those, and feel free to type into the chat box as well if you think we're missing anything along the way. So to get things going, as we invite you to add your comments into the chat box in terms of other things you may have seen or things that are important from a value-based healthcare perspective, we've got a quick poll for you. To what extent do these factors fit with your experience of what drives successful value-based healthcare initiatives, either because you've already embarked on several or because you've observed ones that others may have embarked on? So how does this fit with your perspective? And you'll see the votes coming in. And if this doesn't fit with your perspective, we would love to hear about what's missing or what's there that, frankly, you haven't seen to be of value. So it didn't really matter in your experience at the end of the day. So you can rate it everything from greatly to moderately to somewhat to very little to not at all. And I see the early votes are coming in, suggesting that these factors are resonating for you. But I also do continue to invite you to contribute in the chat box to other things that may not be there. This is an ongoing exercise for us. We're planning to use the criteria that we identify here as a jumping off point for a self-assessment tool. As you're doing that, I want to get in one last question that came across the line, and this is a question that will go to Dove. So Dove, get ready. And question was language and culture considered in value-based healthcare by design or in the examples that you've discussed? So I'll give you an opportunity to respond specifically on that front, and then we'll have a bit of a more general conversation around that.
Yeah, so from a language perspective, we did try to get a diversity on that front, but as you know from our sample size, it was hard. We did also touch on in our interview some of the cultural elements to living with the device, experiencing the device, how that impacted that patient. Probably it's something that we would have focused on more in the future, but yeah, definitely something that we touched on.
Great, thanks, Dove. And then slipping in a couple of other comments just as we're closing out the webinar for today. So the first is Neil was only able to present a couple of slides of his full presentation on the HBEST recommendations. So if you're interested in more, there's a link that's been put into the chat box in terms of more information on the slides and Neil's blog about value-based procurement. We will also be sharing the recording from today's webinar within a couple of business days, so you'll get access to that as well. And then there was also just a couple of questions on the last information that I presented in terms of, does this exist somewhere? And indeed it does. There was a summary of the design day that was the genesis of these criteria that's available at the link that Bill shared earlier, that's also in the slides in terms of resources that are available coming from this work. And we will also be sharing, as it's tested, because we're in the testing mode right now in a co-design way, the self-assessment tool that comes out of that. And then the other question that came up, a couple of comments actually in terms of the criteria, where are the patient foundations of value? Super important question, and actually that flags for me that maybe some of these labels aren't as descriptive as they might be, because certainly the whole point of having meaningful metrics is meaningful metrics for patients based on the outcomes that matter to them from their experience. And so we probably need to do a better job of describing how that is driven by the patient and family experience and how central that is. We've had a few other comments and questions, but I'm getting the signal that we are right at 1 o'clock. And so if you didn't have a chance to get your question on today's live session, we will be following up after this webinar and sharing the answers to questions within the session that came in within the session materials within 2 business days. And you also hopefully know where we are and how to get a hold of us. You've received emails reminding you of this webinar. And so if there are other ways that you wish to interact with us over time, please do. And I'll just conclude today by a big thank you to Neil and Dov for their terrific presentations and sharing their experiences today. And to everyone on the webinar for participating in this process, for your great questions, your feedback, your insights. We look forward to continuing to connect with you, including if you're interested in joining us at our next webinar 1 month from now on Friday, March 15th. This would be February, next month would be March. And at that webinar, we'll be highlighting some of the innovative work happening in value-based healthcare in both Quebec and New Brunswick. I hope that you can join us then. Goodbye for now, and for those of you who are shortly heading into your weekend, depending on your time zone, have a wonderful weekend. Thank you very much.
This concludes today's call. Thank you for your participation. You may now disconnect.